Hello, my name is Peter Lawrence, and I'm pleased to introduce the April issue of the Journal of Vascular Surgery and highlight 4 outstanding papers which are freely available for the next 2 months. The editor's choice and CME article for this issue is Stable 2 Clinical Trial on Endovascular Treatment of Acute Complicated Type B Aortic Dissection with a Composite Device Design by Lombardi and co-authors. They evaluated a composite device design which consists of a covered stent graft and a bare metal stent for the treatment of patients with acute complicated type B aortic dissection, presenting with aortic rupture or branch vessel malperfusion. 73 patients were treated. 27 presented with aortic rupture, and 78% presented with branch vessel occlusion or compromise, including 4 patients with both conditions. The covered stent graft was used in all patients, and the bare metal stent dissection was used in 80%. The 30-day mortality was 7%, and the 30-day major adverse events included myocardial infarction, bowel ischemia, renal insufficiency, renal failure requiring dialysis, stroke, paraplegia or paraparesis, and prolonged ventilatory support. 9 deaths occurred from 31 to 365 days, with only 1 death related to dissection repair. The freedom from all-cause mortality was 80% at 1 year. Within 365 days, 12% underwent secondary interventions, but no patients required conversion to open surgery. At the 12-month follow-up, complete or partial thrombosis of the false lumen was seen in 100% of patients within the stent graft region and 97% within the dissection stent region. Our next highlighted article is entitled Surgeon Specialty Significantly Affects the Outcome of Asymptomatic Patients After Carotid Endarterectomy. Boitano and co-authors from Mass General Hospital evaluated the impact of a surgical specialty on carotid endarterectomy outcomes using a NSQIP quality database. 21,060 carotid endarterectomies were identified, with 93% done by vascular surgeons. In the asymptomatic carotid endarterectomy, vascular surgeons had lower unadjusted stroke and death rates. After risk adjustment and propensity weighting, these differences persisted. This study identifies the vascular surgery specialty as having significantly better outcomes after carotid endarterectomy in patients who are asymptomatic. However, the difference in stroke and death was not apparent in the symptomatic group. The third article, by Karkanian and Oderich and co-authors, is entitled Cerebrospinal Fluid Drainage Complications During First Stage and Completion Fenestrated and Branched Endograft Aortic Repair. They assessed the race and risk factors of complications related to CSF drainage during fenestrated, branched, or endovascular aortic aneurysm repairs of pararenal and thoracoabdominal aortic aneurysms. 187 patients were treated for 20 pararenal and 167 thoracoabdominal aortic aneurysms and received CSF drainage in 240 procedures. 10% had CSF-related complications after the aortic procedures, and these complications including 6% with an intracranial hypotension, 2% who had intracranial hemorrhage, and 3% who developed spinal hematomas. Fluoroscopic guidance was used in 18% with a lower rate of technical difficulties compared with a blind approach. Of the 13 patients who developed spinal cord injuries during aortic procedures, 31% were attributed to complications of CSF drainage. The authors then recommended that the use of spinal cord drainage should be carefully weighed against its potential benefits, and that fluoroscopic guidance may decrease drain-related complications. The final article in this issue highlighted this month is Outcomes of Atherectomy for Lower Extremity Ischemia in an Office Endovascular Center by Jane and colleagues. 352 lower extremity atherectomy revascularization procedures were performed using either laser or orbital atherectomy, followed by angioplasty or angioplasty and stent placement as needed. Atherectomy was performed in 282 patients in 352 limbs with an average age of 69. Technical success was achieved in 571 of the 594 vessels treated. 23 of the 352 required major amputation within 30 days for pre-existing disease. The primary patency was 90% at 12 months and 84% at 29 months. And there was a significantly increased risk of occlusion of vessels treated with laser atherectomy compared with orbital atherectomy, but no difference in the risk of occlusion between atherectomy and angioplasty compared with atherectomy, angioplasty, and stenting. The authors concluded that atherectomy in conjunction with angioplasty and or stenting had satisfactory patency with minimal complications and carried out in an office-based setting, but various atherectomy devices result in different outcomes. Thank you for watching. For more information, please follow us on social media, and remember to like, comment, and share. We hope that you enjoyed these 4 highlighted papers and the other excellent papers in this month's Journal of Vascular Surgery. And remember that these articles are free to read until the end of May. Thank you very much for your attention.